L-Carnitine supplementation for non-alcoholic steatosis and steatohepatitis by Amy Schlepper, peer-reviewed by Kristen Schurer. Background. Non-alcoholic fatty liver disease is the most common liver disease in the U.S. It is also called hepatic steatosis, and it is defined by the presence of fat accumulation in the liver. Although it is considered to be reversible and theoretically benign, it can progress to non-alcoholic steatohepatitis, or NASH, which is when the fat causes inflammation and scarring or fibrosis of the liver. It could lead to cirrhosis, liver failure, or liver cancer if not reversed. It is difficult to estimate the current prevalence of fatty liver disease due to varying definitions, biochemical versus histological. However, one study showed that between 1988 and 1994, estimated prevalence of fatty liver disease was 19% of the U.S. population, or 28.8 million Americans. Prevalence was increased in Mexican Americans, older adults, and obese and diabetic populations, and among those with a higher waist circumference. Pathogenesis. The exact disease process for fatty liver development is not fully understood, but mitochondrial dysfunction likely plays a role. The prevailing theory is that of a two-hit hypothesis, where the first hit occurs by way of fat accumulation in the liver. Fatty liver is associated with obesity and metabolic syndrome, most particularly insulin resistance, increasing susceptibility to fat accumulation in the liver. Circulating free fatty acids and triglycerides are thought to be the main contributors to this fat buildup in the liver. This fat deposition then increases oxidative stress and mitochondrial damage, causing the second hit. Beta oxidation and the role of L-carnitine. The body synthesizes acetyl L-carnitine from two amino acids, lysine and methionine, in combination with other nutrients. But it can also be obtained from food. Carnitine plays a crucial role in energy metabolism, as it transports fatty acids across the inner mitochondrial membrane for beta oxidation. Carnitine is not considered essential since the body can make it, and since upwards of 90% of carnitine filtered by kidneys is reabsorbed. Absorption increases as carnitine needs increase. However, it has been theorized that supplemental L-carnitine may increase fatty acid beta oxidation, reducing the presence of fatty acids in the liver of those with fatty liver disease or NASH. In fact, the enzyme that uses carnitine as a cofactor, carnitine palmitoyl transferase 1, or CPT1, is underexpressed in NASH patients, and some have suggested this could be a possible etiology in fatty liver disease development. In rodent models of NASH, CPT1 activity is observed to be reduced, but supplemental L-carnitine has been shown to modulate CP1 activity. Via CPT1, carnitine is joined to acyl-CoA to form acylcarnitine, which works with the carnitine-acylcarnitine translocase to support fatty acids from the cytosol of the mitochondria through the outer and inner mitochondrial membranes to the mitochondrial matrix, where acyl is removed from the carnitine to form acyl-CoA and to make its way to the beta oxidation process. Carnitine has been shown to prevent the damage done by free fatty acids to liver and its mitochondria because it clears fat by inducing beta oxidation. June et al. Suggested that free fatty acids impair mitochondrial function, structure, and number. Their research demonstrated that carnitine can prevent this structural and functional impairment in NASH. In their in vitro model, they showed increased CPT1 expression and enhanced beta oxidation. Carnitine also reduced inflammation and reactive oxygen species production in their fatty liver disease model, which suppressed the damage done to liver cells, and this was a rodent model. Human clinical trials. Research on L-carnitine supplementation in humans for non-alcoholic fatty liver disease or NASH is extremely limited. All of these studies found biochemical improvements in liver function tests, or LFTs, but improvements as detectable on ultrasound or biopsies seem more difficult to attain. Malaguarnera and colleagues' study was the only one to show histological improvement of NASH or regression of fatty liver with L-carnitine supplementation. Note that Malaguarnera showed L-carnitine improved insulin resistance, which is considered a critical piece in non-alcoholic fatty liver disease pathogenesis. Even on a 1,600 calorie diet, which was not individualized to subjects' energy needs, There was no significant change in weight, so results appear to be the effect of L-carnitine and not weight loss. Lim et al. Evaluated mitochondrial structure and function in addition to LFTs. Mitochondrial DNA copy number is thought to be a reflection of the number of mitochondria, since a post-treatment increase in mitochondrial DNA copy number would theoretically reflect increasing organelle number. Lim et al. Theorized that carnitine supplementation and non-alcoholic fatty liver disease may be associated with a suppression of mitochondrial death and with reduced oxidative stress. L-carnitine sources. Carnitine is found in high amounts in beef, ranging from 56 to 162 milligrams per 4 ounces cooked. No other food really comes close, although whole milk is the next highest source at 8 milligrams per cup. Carnitine is found in the two isomers D and L, but L is considered the biologically active form. In food, it is found in the forms of L-carnitine, acetyl L-carnitine, and propionyl L-carnitine. Varying forms and doses are available to the consumer, and they are discussed a little later. Of note, L-carnitine differs from acetyl L-carnitine, which has an added acetyl group. This gives acetyl L-carnitine a different function, since it donates acetyl groups to other compounds in the body. It can donate acetylcholine and is therefore used for treatment in neurological conditions. Efficacy and safety. The purpose of this paper is to evaluate the effectiveness of L-carnitine in improving non-alcoholic fatty liver disease and/or NASH, although it has been evaluated for other conditions, as summarized here. Regarding safety, L-carnitine is considered likely safe when used orally and appropriately. L-carnitine is considered to be safe at intakes up to 2,000 milligrams a day for chronic supplementation. This is considered the observed safe level, or OSL. There is insufficient research at higher doses to recommend long-term supplemental intakes above that amount. It is considered possibly safe for use in children when used orally or intravenously and appropriately, and possibly safe for use in lactating women when used orally. There is, however, insufficient reliable information available for use in pregnancy, so avoidance is recommended for that population. Brand ratings. The Natural Medicines Comprehensive Database was utilized to form this table, which provides a sampling of brands that have been evaluated for evidence-based effectiveness. NMBER stands for Natural Medicines Brand Evidence-Based Rating, and it is used on a scale of 1 to 10 to rate the effectiveness of the product, with the higher numbers representing a more effective, safe, and high quality of that supplement. Cost was not analyzed, nor were additives or excipients listed here. Drug interactions and adverse reactions. Certain medications, valproic acid and pivulic acid, can deplete L-carnitine. Therefore, L-carnitine status should be monitored with their use. L-carnitine can also interact with certain medications, acenocumarol or Syntrome, thyroid hormone, and warfarin or Coumadin. L-carnitine has been associated with nausea, vomiting, abdominal cramps, heartburn, gastritis, diarrhea, body odor, and seizures. One of its metabolites can cause the urine, breath, and sweat to have a fishy odor. D-L-carnitine should be avoided as a supplement as it can cause myasthenia syndrome with severe weakness and muscle wasting. D-L-carnitine is theorized to compete with L-carnitine, which leads to L-carnitine deficiency. Other health risks and concerns. There are conditions where supplemental L-carnitine would be contraindicated. In particular, L-carnitine can't interfere with thyroid hormone, which is why it can interact with thyroid hormone when it is used as a medication. Therefore, L-carnitine should not be used or supplemented in hypothyroidism, as it could further exacerbate this condition. This presents a challenge if L-carnitine is ever to become a part of treatment for fatty liver disease or NASH, since hypothyroidism is actually more prevalent in fatty liver disease and NASH. A recent paper published in 2013 suggests that a metabolite of L-carnitine could worsen atherosclerosis in some people. L-carnitine is metabolized to trimethylamine N-oxide, or TMAO, by gut microbiota, and TMAO is proatherogenic and could increase cardiovascular disease risks in those people. It was not identified which gut flora, either friendly or unfriendly, was more associated with TMAO production, but omnivores seem to be more likely to make TMAO from L-carnitine supplementation than vegetarians or vegans. Conclusions. L-carnitine shows much promise for improvement of non-alcoholic fatty liver disease and NASH. Studies continue to show improvements in AST and ALT levels, but further research is needed to confirm regression histologically due to L-carnitine supplementation. At doses of 2 grams per day, research supports its safety as a supplement, except in certain populations, those with hypothyroidism, pregnant individuals, and those treated with acenocumarol or Centrum, thyroid hormone, and warfarin or Coumadin. Recent research linking L-carnitine and promotion of atherosclerosis are concerning. However, the research taken as a whole suggests L-carnitine is safe at 2 grams per day. There is not enough research to support its efficacy for treatment of non-alcoholic fatty liver disease or NASH. Therefore, this author gives this rating. This symbol means that preliminary evidence from a few controlled trials in humans support efficacy claims, but more research is needed. References are included here for your convenience. Thank you.